consistent drops of QRS. So the P waves are consistent and drops of QRS. So just in discussion purposes, our favorite word weeks ago, right, was perfusion. So if we already know that it goes SA to AV to the bundle to Purkinje, right? We're going atrium to ventricle. What's not happening when we have second degree AV block 1 and second degree AV block 2? Perfusion. That's a word you guys should have yelled out at me. Perfusion. These patients are not perfusing. Okay? Then we move in to third degree AV block, also known as complete.
I have a question about like the winky block. Since like the PR interval is different for each one, can you measure the PR interval?
You really can't.
Okay.
Yeah, I mean you could. You can say, okay, this one was this one, there's no
You have to
reason.
do it individually.
Yeah.
Okay.
Yeah. For testing purposes, from here until the final, and you guys get blessed to go on and take NCLEX and pass on your first dry. One thing that you will see is you won't have to tell me any of this, but this is your work to get to the point of interpreting, and you have to word the rhythm properly. So if you don't choose the right rhythm name, then you get it marked wrong. So you will actually have strips on test from now until moving forward. So just so you know that.
And we would call it second degree AV blah, blah, blah.
Yes.
Okay.
Yes. Some people will try to spell winky back. As long as I know what you're trying to spell, I'm good. But if it's not winky back and you try to spell that, then obviously it's going to be wrong. And if you put normal sinus bradycardia, wrong. Because again, we just said it's not normal to be bradycardic. Okay? So here's what second degree AV block type 2 looks like. Constant and drops of QRS. So the P waves are constant and drops of QRS. Then we go into third degree. Perfusion, perfusion, perfusion. This is even bigger. So when we're looking at third degree or complete heart block, called the same thing, there is no means to the madness of our P waves and our QRS. If you look at this too, is this a P wave? Is this a T wave? What is that? There's no means from the atrium to the ventricle. They're beating when they feel like it. Okay? Definitely perfusion. You will see patients that are symptomatic with this, just like you would in sinus bradycardia, symptomatic bradycardia. So we'll talk about those a little later too, as well. So third degree, no means, no relationship between the P's and the QRS's, by definition. So those, we're moving on to atrial. So when we're talking about atrial arrhythmias, or dysrhythmias, however, they're interchangeable, one thing to think about when we're talking fibrillation is it's actually quivering or fibrillating. So we already said if it's atrial, what do you think we're not going to see? Atrial fibrillating.
P waves.
P waves. So that tells you we cannot measure a P at our interval because we have no P wave to start. And I'll prove it. Excuse me. Again, don't get concerned with the QR's S's being flipped down below the line of scrimmage. Again, being on that line across. Don't be alarmed by that, okay? One is we go back to basics. So, number one says, I look for irregular or regular. Is this irregular or regular?
Irregular.
Yes, so ours do not match each other at all, so it's irregular. Then, can I identify all my PQ, RS, and T's?
No.
No, what is missing? P's. Some people would like to argue, well, that looks like a P and maybe that looks like a P, but how do we know that? When the atrium is fibrillating or quivering, same words, okay? Then, if I don't have a P wave, I can't measure QRS. So that is one thing that tells me that it's an atrial rhythm, right? Because the P waves, as we said here, are atrial. Then, our QRS complex, we could measure, looks like 2 boxes. So that's 0.08, that's normal, so that's what it's got going for it. And this heart rate. 80s, correct, yep. 80s, whoop whoop. So, this is what, by reason, it's atrial fibrillation or AFib, people call it. This is the word that we use when it comes to atrial the atrial arrhythmias is controlled or uncontrolled. So this right now is a controlled atrial fib, which means that the heart rate is less than 100. That is controlled. So then the next step is anything that's over 100 is uncontrolled. So when we think atrial fib, we think that because that atrium is fibrillating or quivering, the blood is pooling, so it's more likely to throw clots. Okay? So these patients should be on some type of antiplatelet, anticoagulant, something, right? To prevent clots from traveling. CVAs, PEs, etc. Okay? So atrial fibrillation or AFib. The next one is atrial flutter. When we think of atrial flutter, there's two ways by definition. One, it is a butterfly fluttering, or they also call it a picket fence, or they call it sawtooth, just like you see in Jaws with the white frothy sputum that patients have. They have like the picket fence, or the sawtooth, or the flutter waves from a butterfly, and I'll prove it. Ta-da. So we go back to basics. Is this regular or irregular? Regular. PQRS and T. Good answer, good answer. Well, do we know? Because normally we have one P wave to every QRS, right? We have a lot of them this time. But we should know that it should be an R wave right after the QRS. So here's a P wave, here's a P wave, here's a P wave. Okay? Or a flutter wave, or a picket fence, or sawtooth. So then, the ratio becomes a 3-to-1. So there's 3 flutter waves to every QRS. You also see it represented as 2-to-1, 3-to-1, or 4-to-1. The problem with this is it's not beating normal, right? Even though it's regular, that's great. But the atrium should not flutter, okay, period. Same thing. So when we're measuring, we can't because first of all, which one would we measure? Would we go here? Would we go here? But if we have a long PR, wouldn't that be a sinus with the first degree? Because a PR is greater than 0.20. But, so we can't identify if there's a P wave as a whole, because there's something else in its place, or a couple other things in its place. So that, even though it's regular, there's technically no P wave. The QRS and T are present. Can't measure the PR. QRS, like 1.5. So we can say 0.06. And then heart rate. 60s, for sure. Same scenario. Atrium should not flutter, just like they shouldn't quiver or fibrillate either. Okay? So now we're worrying about pooling as a whole.
And you said there is an identifiable T wave, the one right after.
It should be right after.
Okay.
If you look at it in grand scheme of things, this one does look like this one, that does look like that one.
Okay.
Questions? Yes, Melissa.
When you said why did you say 3 instead of 4? The first one should be there and the other 3 shouldn't.
Correct. Correct.
Is atrial flutter also what they refer to as like atrial?
I didn't hear what you said, I'm sorry.
Is atrial flutter what they like also call like atrial tachycardia? I've heard that term too, and I'm just wondering.
Atrial tachycardia, we're not talking about it here. Big
Okay.
difference. That means that, yeah, the atrial tachycardia means atrium's going way too fast, not catching up to the ventricle. We're not talking about that. That is beyond us and getting our feet wet in the pool. So when we're talking PVCs, we already know premature ventricular contraction. We know by definition, technically, in this class and others, 3 or more PVCs in a row leads to ventricular tachycardia. We know that ventricular tachycardia is one of the lethal rhythms, okay? Period. So, one thing that you're gonna see that I'm not gonna say is this unifocal or multifocal, but I think you need to know in the grand scheme of things because you may see this in practice. When we're talking PVCs, a lot of patients say it's a skip beat or they feel palpitations. So, there's something called unifocal PVCs and multifocal PVCs. A unifocal simply means that it's in one spot of the ventricle that is prematurely firing, okay? In the world of multifocal PVCs, that means that there's several spots illustrated like it is in this picture, that there's several spots in that ventricle that are firing. The reason why I want to show you guys so you're aware is you see that the unifocals look the same, so it's showing you one spot is firing. If you look at the next one with the multifocal, you'll see represented in different colors that there's multiple spots in that ventricle that is firing, or ventricles I should say, that are firing, represented by different colors. Because on a ECG monitor, you're gonna look at this and go, well, the R waves are normal kind of, but the PVC makes it irregular, right? And so you'll be able to identify then the PQ, RS, and Ts with the normal beats. The PR you can measure because it's there. The QRS you can measure. The heart rate, never measuring a PVC, right? Because it's firing and doing its own thing. It's in the 40s. So this would be sinus bradycardia with PVCs. Now, the question comes into play. What do you put in front of the PVC? If I went to my ECG monitor and I looked, and every time I printed off a strip to document it, it had PVCs on it, that would be frequent. But if I had started my shift and I saw one in the morning but didn't see one in my 16-hour shift until later, then that would be occasional. But I would have already done that morning my lab work to check my potassium level on my patient, to check the magnesium level on my patient, to see why they're having PVCs. It is not normal to have PVCs, okay? Unless there's something bigger going on, which very well could be why they came in to begin with. Maybe they're a renal failure patient, etc., etc. So, occasional or frequent. For purposes, you're not going to be able to know if it's occasional or frequent because you're going to get one slide on a test. But know for practice in the future or in clinicals that you see this in the start of your shift, you see a PVC and you don't see one at the end. So that could be just an occasional thing that happened. But again, you correlate it to the lab work of potassium and magnesium because we know already that those can cause PVCs, either low or high. Okay? Here is just an illustration of multi. So you see this PVC looks different than this PVC. Again, different spot where it's happening in that ventricle. So again, you would go back to, well, it's irregular, but we know that sinus is regular. So what makes it irregular is the PVCs. Okay? So we have PQRST all identified in the beats that look normal, right? And then, but we wouldn't say it's normal sinus because it's not normal to have PVCs. So we would call it sinus whatever happens after that. And then we would say, if I saw 2 or more, that would be frequent because it shouldn't be firing willy-nilly. Okay? Good? Makes sense? Okay. Ventricular tachycardia. We're not getting into the narrow or wide VTAC. We're just simply, I'm excited if you guys know what ventricular tachycardia looks like. One thing I always like to say is when I take this strip and flip it upside down, it still looks the same, except it's just upside down, which tells me that it's VTAC. So, 3 or more beats. What happens, here's our normal sinus compared to what VTAC looks like. So this is the ventricular tachycardia. That means that the SA to AV has nothing to do with it. It's all the ventricle. Now we worry again about perfusion. That is one of the reasons why they call it a lethal rhythm. Because VTAC, as you see here, can lead into VFib or ventricular fibrillation. By definition, this is chaotic. You can't measure anything or see anything. And your patient won't see or hear anything either. Because it's a lethal rhythm, right? VFib, we defib with meds on board. And we'll talk more about those. So, plus they're in your handout as well. So, when we're talking lethal, so we have VTAC, VFib, and then one thing that I'm going to jump to is asystole. Because it goes VTAC, VFib, asystole dead, right? And always with asystole, we need to check a pulse because we could run in because the ECG monitor tells me that my patient's in asystole, but the lead just fell off, right? So speaking of leads, how do they work? 5 leads. If I had 5 leads on my patient, where would they be?
Here, 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 here.
Okay, and what would they be? Where
Right.
goes over what?
Like
Black over red.
green.
Smoke over fire, air over grass, brown in the middle.
There you go.
One more time.
Smoke over,
Fire.
smoke over fire,
Left.
air over grass.
Yep, right.
Brown in the middle.
Brown in the middle. Perfect. So, let's go back to Jasad's point. When I said that we would talk about pericardial infusion causing a cardiac tamponade, the cardiac tamponade, so the pericardium fills with fluid, and it compresses on that heart. That leads into cardiac tamponade. We're not going to see that looking into our patient, right? Because they don't have glass or window or whatever. We will see Torsades de points. It's French for twisting of the points. So as that fluid is compressing and causing a cardiac tamponade, this is what you will see on monitor. You will see that it looks like VTAC, VFib, VTAC, VFib, VTAC, all combined into one. This is Torsades de points, is what we call this particular rhythm strip. But again, if you see this, that means that it is compressing on that heart. And we'll talk about next week how to fix that. Well, we can't per se, but we can get the patient ready to be fixed. Questions about any of that we talked about? We're good. If you have questions, please don't hesitate to ask now, or you can always ask me later or email me. AV pacing. So when we're talking pacing in general, there's actually more ways, but we're just going to cover 3 basics. Atrial pacing, ventricular pacing, and AV pacing. There's other stuff like pacing non-captured, non-sensing. We're not worried about any of those. What I need you to know is to be able to identify a rhythm strip that either has atrial pacing, ventricular pacing, or AV pacing. Okay? So, when a patient needs to be paced, it's because the rate is too fast, too high, and it's all based on perfusion. Okay? You thought you were done with the word perfusion. Here's just a great picture to see. Here's a pacemaker, and you'll see the leads, we call those leads, that are attached to the endocardium inside the right ventricle and right atrium. So if I was to see this on monitor, because they have a lead in the atrium and a lead in the ventricle, that would be AV pacing. I would see that represented on my ECG. If I only had one or the other, I would see it either the atrial pacing or the ventricular pacing. And how I know that this patient is going to look like this on my ECG. Now, when we go back to regular, we really can't say that this is a QRS in the sense, because it's not their own QRS. It's being initiated by a pacemaker. Does that make sense? Okay. Yes, it looks like there's a P wave, but again, it's initiated by a pacemaker. So, these things that you see in front of the P wave is called a pacer spike. It's actually shocking and showing. It's just an easy way to think about it. So it's shocking that atrium to do something, so it does something. Then it's shocked again to the ventricle to tell it to do something. And so we have a pacer spike in front of what appears to be the QRS. So as we go along, we will see that there's spikes in front of what appears to be the P wave, all the way along, and the pacer spike in front of the QRS all the way along. So we would technically measure pacer spikes. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it's 100. Normally it's at around 80. But for discussion purposes, this one's 100. So you can actually see the pacer spike in front of what appears to be the P wave and a pacer spike that what appears to be the QRS. Okay? So this is AV pacing. If you want to write atrial ventricular pacing, that's your choice. It's easier just to put AV pacing. Not tracing, not, what other ways have I seen it? I don't remember. Tracing, it's not tracing, it's pacing, because it's keeping that patient on that heart rate, pacing it. Ventricular pacing, you will see that the pacer spike is in front of what appears to be the QRS. You don't see anything in front of the P wave. So the atrium itself in this patient is doing it its own, but you still don't need to measure. And pacemakers should be regular, unless you get into that capture and sensing and all that stuff I mentioned before. It would be regular already. Okay? So this is, ventricular pacing. The difference between this and that is with atrial, you would just see this and not that one. So the pacer spike would be in front of what appears to be P wave. Okay? Questions about pacing? Nothing, we're good? Okay. So here is general information on patients with cardiac conditions. Patients who we suspect have anything cardiac going on. The reasons why or the causes that play a role are all of these listed. Lifestyle factors. Obesity makes the heart work harder. Smoking causes cardiovascular disease. Smaller vessels, right? Smaller vessels, more pressure. And then 3 would be menopause, hormone replacement therapy, and the use of contraceptives. More estrogen leads to more clotting. Moral of the story. Health assessment interviews. 1, we do WILDA, right? We ask the words to describe their pain. We ask the I for intensity, 0 to 10 on a pain scale. Location of where exactly is the location. And if it goes anywhere, right? We want to know if it radiates anywhere or stays in the same place. The duration of how long it's lasted. And then aggravating and alleviating factors. What makes it better or what makes it worse. So in the world of cardiac, and they're having, let's say, chest pain or angina, one of the biggest things we know about angina is the heart is asking for oxygen. We know that already. We need to help with them and decrease that O2 demand for them because they don't have enough supply, and that's why they're demanding oxygen. So we need to lower that. In our assessment-wise, we're finding out if the apical is regular or irregular, any lung sounds, do they have edema, do they have ascites, do they have anasarca, any of that generalized edema, do they have any of that associated with their cardiac condition. Words, angina meaning chest pain, acute MI, life-threatening, congestive heart failure. Keep in mind, a patient who has a history of congestive heart failure doesn't walk away saying, oh, I have congestive heart failure, because they are not, the tank is not full for them. They have a history of heart failure. As the aging heart happens, that is one of the reasons why patients develop heart failure. Also some other things, congenital heart disease. They've had heart disease for extended periods of time. Valve disease can also cause a heart failure. MIs can cause heart failure. Alcohol use can cause heart failure. So when we mention heart failure as a whole, we're talking about that pump being decreased. That function is decreased. When the congestion happens, it backs up in that right-sided, left-sided, and becomes congestive heart failure. Dysrhythmias, looking at ventricular, we have that VTAC, VFib, asystole. The valvular disease infection, patients with rheumatic fever history are more prone to getting cardiac or carditis infections. And they tend to have infections on the valve. If you ever get the chance to see a TE or an echo that has a patient that has an infection in the endocardium, you'll see on the valve that it actually looks like a broccoli. And that's not normal. So it should be a thin piece that looks like spaghetti, but in picture it looks like broccoli flapping in the wind. So that is an infection, and it's caused by, 9 times out of 10, that rheumatic fever. There has been a lot of people, when they go to the dentist with a history of rheumatic fever, they always pre-medicate to prevent infection because they did away with it for a while and said, oh, they don't need to do that, and now it's coming back again. Because they're more prone after dental work because it's so close in proximity. So they get pre-medicated before dental work is done. Cardiogenic shock. If you guys had problems with cardiogenic shock with the shock days, please review it, especially for next week. Because it affects the pump. It affects tissue perfusion and it decreases the cardiac output. And so leading to all of those. Coronary heart disease or coronary artery disease means the same thing, all from atherosclerosis. So what happens is those vessels being narrow, right, especially if they smoke or by aging or whatever the case may be, fills up with plaque or lipids or cholesterol or fat, whatever way you want to look at it. Platelets love to stick on it. Platelets are sticky to begin with. That plaque, lipids, and all that is sticky, and now we have blockage formation, where it's a cluster of clotting that leads to MIs in this scenario. So, treatment for the pain relief. We know to relieve them is the Monel, which we'll talk about again next week. Oxygen, 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 right? Relieving them the pain, we'll talk more about. And then slowing the progression if it is congestive heart failure, right, where we see the tanks are full. Nursing diagnosis, one of the biggest things I want to point out though is this fear and anxiety. Patients, especially if they're the caregivers of the family, and you tell them they're having an MI or a heart attack, that would make their stress level even worse and cause more damage to the heart. Because all they start thinking about the fear of death and how are they going to provide for their family if they're gone, right? So that's one thing that we have to keep in mind. Not only all of these, of course, but that psychosocial aspect as well. So review. PR normal is what?
0.12, 0.20.
0.12 to 0.20. Perfect. How about QRS?
0.04 to 0.12.
0.04 to 0.12. Heart rate. If I have a patient, I'll give you a hint, that way you don't just willy-nilly throw stuff. If I have a patient that has a heart rate and they're in atrial flutter and it's over 110, what would we call them? Uncontrolled atrial flutter. If I have somebody that's in AFib and their heart rate's less than 60, what would I call them? Controlled, or just leave it alone and just call it AFib. Okay? What would I call somebody less than 60 in a sinus rhythm? Bradycardia. Yep. How about somebody who's over 100 with a sinus? And then SVT heart rate's over what?
160.
Perfect. By definition, when I say that the patient, oh, it looks like it could be second degree Mobitz type 1, how would I know by definition?
No, the PR gets longer and longer.
Yep, PR gets longer, and drops the QRS. That's second degree type 1. Yep,
Type 1.
so the PR gets longer, drops. So Robert's going to tell you what second degree type 2 is.
That's when the P wave is constant, and then it drops to QRS.
Yep, constant P's and it drops the QRS. Yep. How about sinus with a first degree AV block?
PR interval is longer than 20 or 0.20.
So the PR, so first let's back up. It's regular. PQRST is all identifiable. The PR is greater than that 0.20. QRS is normal and that heart rate is dandy, right? How about third degree heart block?
There's no means of measuring at all.
No means of anything. No correlation between the P's or the QRS's. Perfusion. So we didn't mention as asymptomatic bradycardia, but we will now. Patient's heart rate's less than 60 and they become symptomatic. Okay? What symptoms do you think you'll see in a patient that has low heart rate?
Slow.
They're going to be slow. Yes. Very. What else? What did you say? Dizziness, yes. Confusion. Weak. Malaise. More than just fatigue, it's malaise.
Could they be cold? Because like the perfusion, like.
They could be. They were going to be confused and probably won't even know they're cold. But they could be, most definitely. What else? Yes, they could be pale. Yep, lack of perfusion, good.
Short of breath, harder to.
Could be short of breath. What'd you
Is
say?
it harder to identify like the peripheral pulse or something like baby?
Could be because it's weaker. Yep. And that's kind of where the Peller comes in. Cap refill might be in the doorlet, right? So what can we do for these patients? Pray. All right, not epi. Why not epi?
I don't know.
Yeah, you do. You do, Haley. Why not epi?
Why not again?
You do. What does epi do?
Make the heart rate go faster?
It does. However, what does it cause? Causes vasoconstriction. So if I have somebody, see, now it makes sense, huh? So, yes. So what's another drug we can give that increases heart rate? Atropine. Atropine is the drug of choice. Now, as we're getting that atropine ready, what is something else we can do for that patient?
stimulate them?
Unstable.
Yep. If they're severely unstable, we can get ready to pace, a temporary pacemaker. And we give that atropine. Then we give them and send them to cath lab for a permanent pacemaker. Good thinking. I like when you say epi though. So that's a high five. It wasn't anything bad, Haley. It was a good thing. You gotta think it out. Yes, Jessica.
When you say send them to cath lab and get them a pacemaker,
Permanent pacemaker.
permanent, how long would they have to have bradycardia for you to do something so invasive?
It's all about perfusion. If the stuff that we're doing, it's not fixing the problem, or it's only a temporary fix, then we need to send them.
Okay,
So this is not gonna be somebody who just walks in the door who has led a healthy life that has a problem. We might find that they have sick sinus syndrome that gets them to that point. But patients that come in that have been sick sinus syndrome, because there is a disease process that's called sick sinus syndrome, that the SA node is sick. And so it's not firing like it needs to. If it doesn't fire to that AV node, how is it gonna do anything?
okay,
So then, perfusion, and they start having more bouts of those.
okay.
So, I mean, it's, of course, patient-based and comorbidities and all that stuff plays a role, but that is the treatment plan, is atropine, a temporary pacemaker, and then get them to a permanent pacemaker with symptomatic bradycardia. Okay? So we talked about that. What else were we supposed to talk about? We talked about the drugs, because we mentioned atropine. That's what I wanted to do. Okay, yay.